Now that we have completed the frontal lobe, let's move on to the parietal lobe. So the parietal lobe is located right behind or posteriorly your frontal lobe and in anterior to the occipital lobe. And here are some of the substructures of the parietal lobe, such as the somatosensory cortex, which is the most important one, specifically from the point of view of patients that you may regularly see in your PT clinic. So you may see patients who have primary somatosensory cortex impaction or secondary somatosensory cortex impaction, but you also have the inferior parietal lobule right here, the precuneus region, and the superior parietal lobule. So moving on to the most important part, as I just mentioned, is the primary somatosensory cortex, and it is located in the post-central gyrus, just behind the central sulcus. So the function of the primary somatosensory cortex is to identify location of stimuli based on touch and discriminate among various shapes, sizes, and textures of objects. Now, mind you, when we say discriminate among various shapes, sizes, and textures, we mean by touch. So when you talk about somatosensory cortex, it's important that you're thinking about everything to do with touch or pressure, but not visually. I'm saying this because sometimes you do get, sometimes some students do get confused when you get a question on the exam and says, what's the primary function of the primary somatosensory cortex? And there will be options like discriminate between shape, size, and textures by touching them, discriminate among shape, size, and textures of object by visually seeing them. And some students sometimes do select visually seeing them, but please know that this is the somatosensory cortex and it is related to touch. So you're not seeing the objects. I mean, you may be able to, but the true test of the primary somatosensory cortex would be to blindfold your patient and ask them to discriminate objects. It also has some function to recognize pain and temperature sensation, but that's more widespread because that is recognized by a midbrain. So if you want to test your primary somatosensory cortex, a good way to do it would be to draw shapes on your palm with your eyes closed and see how, if you can recognize the shape, or if you could do it with a friend. So when you may see patients with stroke again, or TBI or MS, who may have impaction of the primary somatosensory cortex, and they will have widespread loss of touch sensation, of pressure, of proprioception in the opposite side of their body. So it's very important for you to assess their touch and localization sensation as well as their proprioception to ensure that this cortex is not impacted. So losing partial sensory loss is called as paresthesia, and complete sensory loss is called as anesthesia. All this information is in the notes of my slides. So if you feel like I've not written it on the slide, it's because there's too much information to write on the slide. So you will find all this information in the notes of the slides. Moving on, the next area that we want to remember is the parietal association cortex. And this is the area that processes visual, vestibular, and acoustic sensory information. So this is important when you consider a movement as a whole. For example, if you want to kick, again, using the same example, kick a soccer ball into a goal post, you will use a lot of your visual sensation. You also get feedback from how hard you kick the ball, because you will get some sensory feedback as well as auditory feedback. So your parietal association cortex processes all that information together to create a smooth movement. And it also has a large role in spatial cognition and motor control of the eyes and extremities, because again, this is very important when you conduct any type of fast movements, specifically sport-related movements, or even simple walking requires spatial cognition, which means realizing where your body is in space, as well as motor control of your eyes and extremities. And finally, this area also helps with language and math processing. So that was all regarding the parietal lobe. Moving on to the occipital lobe. So the main structures over here are your primary visual cortex, your secondary visual cortex, and the lateral geniculate body. And as you know, the main function of the occipital lobe is to process visual information. So the primary visual cortex distinguishes between light and dark, as well as various shapes. But now we are talking about visually discriminating various shapes, as well as location of objects. So if you have a busy desk around you, and if you want to find an object on your desk, then your visual cortex will help you do that. And it also processes movements of objects. So when you watch like a football game, or when you watch TV, you can see all those movements occurring, and that is processed by our occipital cortex. So the pathway for processing visual information, if you remember, this is a shortened pathway, but still, if you remember, your visual information is processed in your retina, then it goes into the lateral geniculate body of the thalamus, and then to the primary visual cortex. And if you see patients who have anything wrong in this pathway, then they will have some or the other visual disturbance, and they may not be able to recognize like shapes of objects, locations of object, as well as movement of object. And this the occipital cortex is frequently affected in people with multiple sclerosis, as well as in TBI. So we'll cover multiple sclerosis in your summer semester, and we'll discuss more that time, but it's important to remember your neuroanatomy for your occipital cortex for these patients. Okay, moving on to the temporal cortex. So in the temporal cortex right here, we have the Wernicke's area, which is a very important area in terms of stroke and in terms of the types of patients you may see in your clinic, as well as the auditory cortex. So this is the Wernicke's area and this is the auditory cortex. And then your temporal lobe itself is divided into superior, middle, and inferior temporal gyrus or gyri. So looking at the Wernicke's area right here, it is obviously close to the auditory area. It's because the Wernicke's area is related to language comprehension. So the fact that you can understand me right now is because your Wernicke's area is intact and because I'm speaking the same language that you understand. If I start speaking in Hindi, maybe you will need a translator and you may not understand it. So that's just related to a different language. It's not like your Wernicke's area is impacted. But if for patients who have their Wernicke's area impacted, for them, when you speak to them, it's like you're speaking in a different language. But what's funny, not funny, is that they don't realize that they're not understanding you. So if you remember this video, you will see these patients who will be very fluent in what they speak to you, but it will not make sense. And they will also not have the insight that they are not understanding you. So they cannot comprehend language, but they can speak very fluently, but their language will not make sense. It will sound more like gibberish mixed with some comprehensible words here and there. So, and that's why this is called as a sensory aphasia, because you're not able to sense the language, or receptive aphasia because they're not able to receive the language, or fluent aphasia because they speak very fluently, but it does not make sense, and that's why it's called aphasia. So again, let's look at this person here. You have seen this video again in your first year, but again, I would encourage you to see it now from a patient perspective. And when you see people with Wernicke's aphasia, it's very important to use simple commands and actions when you speak to them. So instead of, say you're explaining a gait task to them and you want to tell them that you are going to walk from point A to point B, and you're going to put a gait belt on and I'm going to be there with you, and don't worry if you feel like you're falling, I'm going to hold on to you. Instead of giving all those instructions which are useful for people who can understand you, you can just say walk. And then when you come to point B, you can say stop. And they may be more likely to understand simple one-word commands than a whole 3-sentence command regarding gait training. And then, of course, actions do help. So let's watch this video here. I really like to watch this video because I find this guy so cute, and the way he talks, it just makes me very happy.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing. Like here?
I'd like my change for me and change hands for me. With happy, I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them.
Good.
This girl was very good. And happy when I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for for us, other hands. I don't know what you get, but I talk with a lot of hand for him.
So as you can see, he's talking in English, but it's not making any sense because there is no grammar there. You can pick up words, but again, we don't even know what he's saying is truth or not. And he's definitely not responding to the questions that he's being asked. And he also does not show any insight of him understanding that he's not answering the question. He's just talking and talking and talking without understanding that it's not making sense. And that is what Wernicke's aphasia would look like. So actions and simpler commands would help. And of course, speech therapy helps them. So with time, they do get better, but not to 100%, or it depends on each patient whether they will get to 100% or not, and the severity of their stroke. But it definitely helps to give shorter commands and use actions. We'll finish watching this video because I love the last sentence of this video.
Sometime. Am I talk of any more to saying?
All right. Thank you very much.
Thank you very much. I appreciate it, and I hope the world lasts for you.
Thank you. It's been a pleasure. Bye-bye.
Have a good day.
I hope the world lasts for you. And you saw that he said, have a good day. So sometimes they are able to say like hello or have a good day or bye as regular sentences because it does become a habit to say that, or it's easier. It's like learning a new language all over again, or without understanding that what you're saying does not make sense. So it is a difficult situation for them. So next we are going to learn about the parietal, temporal and occipital association area. And this area, as the name suggests, combines information from all these lobes, the parietal, occipital and temporal lobes. And again, it leads to fluent functioning of our daily actions. So these are higher perceptual functions related to somatic sensations, hearing, as well as vision. And it helps with reading, symbol processing, calculation, self-processing, working memory, musical memory, face and object recognition. So if someone has an impaction in this area, they may have difficulty with like face and object recognition. They may have difficulty reading. They may have difficulty symbol processing. And again, when we cover specific diagnosis, we will talk about this area. So for now, just file it in your brain somewhere, in your prefrontal cortex.